I'm very honored to be with my brothers and sisters in the audience and those who are helping patients to achieve their goals, which is to be free of symptoms and to have a better control of their disease. So management of spondyloarthritis is very appropriate topic, and I will start with let's see, first slide. These are my disclosures, and the topics for discussion, you notice management is at the end, and I will start with just clarifying the name. For example, now we know ankylosing spondylitis, spondyloarthritis, and axial spondyloarthritis, undifferentiated, and so on. So it's quite confusing, and I would clarify that, and then briefly discuss clinical manifestations so that you know what are the problems patients face that need to be managed, because there are a lot of comorbidities as well. And the disease in women. Women were thought 50 years ago to represent only 10% of the patient population. So the ratio between males and females was 10-1. Then over the years, the disease was being recognized more often in women. So up until recently, the ratio in textbooks is 2.5 to 3 times more common in women than in men than in women. But I will tell you that women are not so lucky. The disease prevalence is almost equal. And but women illness is a little bit what people call atypical. I will call it in quotation marks, because unfortunately the typical pattern was male dominated when most of the people thought is a disease of men. But men do get more severe disease. Women can also, but generally speaking, in women the disease evolves a little bit more slowly, generally. And the presentation can be, well, not always low back pain as the first symptom. And so there is need for early referral and early diagnosis, because now we can do much more than even 10 years ago for this disease. And so this particular slide shows that the illness can begin in childhood. And the mean age of onset of symptoms is, a first symptom is anywhere from age 12 to age 40 or 45. It's very uncommon for the symptoms to begin outside that range. So this is age of onset of symptom. Diagnosis is delayed by many years. And so here is an example of spondylitis and of juvenile onset. And the word spondyloarthropathies has been used for this condition. And the word spondyloarthropathies is a little bit less accurate. It implies that there is inflammation with predilection to involvement of the spine, therefore spondylo. Arthropathies meant that many patients can have peripheral joints inflamed as well. And spondyloarthropathy sounds very easy to pronounce, especially the plural is very easy, spondyloarthropathies. If I tell you the plural for spondyloarthropathy is spondyloarthropathies, but there is a new term being used now called spondyloarthritis, because arthropathy means there is a pathology, it doesn't identify that it is inflammatory. So spondyloarthritis is preferred term now, and it encompasses all different types of spondyloarthritis. And the plural for spondyloarthritis is spondyloarthritis. I have to bend my hip joint to pronounce it accurately. But spondyloarthritis is more accurate. And if you can't pronounce the plural, you can say many forms of spondyloarthritis. So this one, juvenile onset, you can have a disease exactly like adult onset disease, which was my situation when I was 12 years old. I had typical low back pain and also neck pain and a lot of chest pain and hip joint involvement. I didn't have any inflammation in the feet or the knees, and but that is the classical juvenile ankylosing spondylitis. And but many more young adults can have inflammation at the site of attachments of ligament and tendons to the bone. Those sites are called entheses. And enthesitis means plural, means inflammation at where infrapatellar tendon gets inserted into tibial tubercle, or the quad muscles attached to the kneecap, or muscles that are attached to the rim of the pelvis, or greater trochanter, or where we sit on the bone here, and feet, Achilles tendinitis, painful heel. And so this kind of inflammation is called, it has been given a name of enthesitis-related arthritis, ERA. Now, so I've told you that here I explained the typical AS, so this is juvenile AS. So next slide shows you the two categories I've already discussed: enthesitis-related arthritis and juvenile ankylosing spondylitis. And there's another term that has been coined to emphasize enthesitis as well as arthritis and SCA syndrome. And there are, like adult patients, one can have these diseases in association with inflammatory bowel disease, as a reactive arthritis from Shigella, Salmonella, gut inflammation, and psoriatic arthritis. So this whole thing is juvenile spondyloarthritis, and ERA, enthesitis-related arthritis, tends to encompass most of the patients with this condition. And then there is another term called undifferentiated spondyloarthritis in adults, and in children it can be peripheral arthritis and enthesitis. Examples are an adult patient who has painful Achilles tendinitis and has had an episode of eye inflammation, but no other symptom whatsoever, no back pain, nothing. So that can be, it looks like it is spondyloarthritis, but it doesn't show the full spectrum. So the name given to this entity would be undifferentiated spondyloarthritis. And it can evolve over the years into one of those pigeonholes. Some of patients may evolve into clear-cut ankylosing spondylitis, others may evolve into psoriatic arthritis, others may evolve into just a condition where they stay limited in this situation, don't develop other conditions, and some may develop Crohn's disease or ulcerative colitis. And in south of the border in Mexico, the disease is quite common, but the pattern is often childhood onset among Mexican mestizos. Mestizos are basically the native population with minimal Hispanic admixture genetically. And they can have, like a 12-year-old boy more often, will have inflammation in the heels and inflammation in the joints of the feet and sometimes other peripheral joints. And some of these children then can actually fuse up the foot. The foot looks like on X-ray as if it's a fused spine. They have just no back symptom. When they reach age 17 or so, then many of these children evolve into ankylosing spondylitis because they develop inflammatory back pain and they have X-ray evidence of sacroiliitis, which is the definition of ankylosing spondylitis. And there are other children who stay in that juvenile AS category as a child, but then as adult, then they are called ankylosing spondylitis of juvenile onset. So the next slide shows that we had all these different names for these conditions encompassed under the term spondyloarthritis or SPA. So we have decided to use the capital S and the lowercase p and capital A to abbreviate spondyloarthritis in publications. So all these diseases do have an association with HLA-B27. So when you come to Cleveland for any reason, when you see the license plate, please do honk and I will respond. So those of us who inherited this gene, perfectly normal gene, with variable prevalence in the world, 95% of HLA-B27 positive individuals never get any problem rheumatologically of this type, but 5% or so. But if you have a relative with ankylosing spondylitis, your chance a little bit higher if you inherit HLA-B27. So it is recently the term axial spondyloarthritis has been proposed that encompasses ankylosing spondylitis. In 1985, we proposed this term spondylitic disease without X-ray evidence of sacroiliitis because we could recognize some patients who did not show sacroiliitis on X-rays, but they had all the typical symptoms. And most of the time they had inflammatory back pain. The criteria that define ankylosing spondylitis require X-ray evidence of sacroiliitis. So typically patients have years of symptoms before X-ray can show sacroiliitis. And defining this disease as ankylosing spondylitis is just like having a rheumatoid arthritis patient who's not diagnosed as rheumatoid arthritis till they develop erosions in their knuckles. And that would be too late. We can recognize rheumatoid arthritis within months of onset of the disease because there are typical symptoms and there are some tests that are very helpful. In ankylosing spondylitis, the main symptom is inflammatory back pain, and it takes many years for the sacroiliac joints to start showing erosions and destruction. That's what is called sacroiliitis. So the term non-radiographic axial spondyloarthritis has been proposed to define the disease before X-rays become abnormal. Once X-rays become abnormal, one can call it radiographic axial spondyloarthritis or ankylosing spondylitis. Not everybody with chronic inflammatory back pain evolves into X-ray evidence of sacroiliitis, and also not everyone with radiographic sacroiliitis progresses on to fuse the whole spine, which occurs because of bony bridging between vertebral bodies. The term for that is syndesmophyte. So the spectrum of so-called axial spondyloarthritis is very wide. Some patients are very lucky, they have inflammatory back pain but never develop full-fledged disease. Then the others who are somewhat unlucky, they develop sacroiliitis, but they are lucky in the sense they don't fuse up the spine. Their disease stays limited in the sacroiliac joint, lumbar spine. But 70% of patients who have sacroiliitis on X-ray, they do evolve into fusion of the spine. And in patients with very severe form of the disease, the fusion happens from the neck all the way to the lumbar spine. So nowadays, it is better to remember this figure, which emphasizes that spondyloarthritis can be predominantly affecting the spine, which will be called axial spondyloarthritis, or predominantly affecting the peripheral joints and minimally low chance of getting axial disease. And so ankylosing spondylitis on the left side, on your left side on the screen, is AS, while there is a green crescent surrounding it, which is non-radiographic axial spondyloarthritis. With passage of time, more and more patients will be recognized before X-rays become abnormal, so that green crescent will gradually increase in size. And it is hoped that ankylosing spondylitis would form a smaller part of axial spondyloarthritis, because we should be able to recognize this disease very early, provided the patients come to us. There are many reasons why they are not referred to us or they don't seek help, but that would be, I won't have time to discuss that in detail. And what will not be discussed today will be peripheral spondyloarthritis, best exemplified by psoriatic arthritis and undifferentiated spondyloarthritis. And I told you about women. Here is the data we presented at EULAR, European Rheumatology meeting, a couple of years ago, where the data from Switzerland. In Switzerland, in 1980, the ratio between males and females was 2.56. That dot in the extreme left part of the, no, sorry, what's happening? I am looking at the screen that is going to be projected. I'm sorry. So this is the ankylosing spondylitis in women versus men. I told you that the prevalence is almost equal, and now I come to what I was trying to say. This is the slide where in 1980 the ratio was 2.56 in favor of men. Over the years, gradually the ratio started decreasing because Swiss Rheumatology Society was very helpful in educating the public about this disease, also working with rheumatologists, physical therapists, physiatrists, and everybody. The disease was then being recognized earlier and earlier. And Swiss rheumatologists are pretty good. Their health insurance is pretty good. One could get MRI without any hassle. So with the use of imaging, such as MRI, even when X-rays are normal, one can confirm or make a diagnosis of this disease, although then it would be called non-radiographic axial spondyloarthritis. So with better understanding of the spectrum of illness, you notice the ratio kept going down and down. By December 2016, the ratio between males and females, 1.03 in favor of men. Okay, so equal prevalence of the disease. And epidemiologic studies have also shown that the disease is as common in men as in women, but the illness in women has, luckily for them, more often not as severe disease. But their symptoms are same level of symptom, because when the disease doesn't progress to bony fusion, they continue to have symptoms. So once the spine is fused, symptoms go away as far as pain is concerned. So these women are now being recognized more and more, which is very important to help everyone with the disease get recognized and treated, because many of these women previously have been told you have fibromyalgia, because they can have presenting symptoms, could be upper back, shoulder area, front, chest, and not typical low back pain, and they look like fibromyalgia type of symptom, till they get uveitis or something else that leads the clinician to suspect this condition. Next. So here is the main pathology, that the inflammation tends to occur predominantly where ligaments, tendons attached to the bone. That is enthesis. So enthesitis is the typical feature, and since vertebral column is basically individual vertebral bodies stacked one on the other, and what holds them together are the ligaments that attach the spine. So those sites are very commonly involved in this disease. And joint inflammation, for example, in the hip joint, when they get involved, There can be some inflammation of the lining of the joint, which is called synovitis, but that is relatively less important or less frequent occurrence, while in rheumatoid arthritis, synovitis is the main pathology where the joints get inflamed because of inflammation of the synovial lining, the joint lining that eats up the bone. So because of enthesitis predominantly, and to some extent some joint inflammation, the spectrum of this disease is very wide. Some patients can only have enthesitis, some patients can have only minimal peripheral arthritis, others can have tendinitis, others can have inflammation around the joints and swelling of the fingers and toes called dactylitis, and then obviously sacroiliitis, spondylitis, and ankylosing. So here is the wide spectrum of this disease and associated manifestations and comorbidities. I already discussed the axial axial disease, enthesitis, peripheral arthritis, dactylitis. But then in this disease, even though the bone forms and it tends to fuse up the spine, there is net loss of bone. So osteoporosis or osteopenia is a very important component of this disease. So it's paradoxical. On the one hand, you are losing bone mass, but on the other hand, certain structures fuse and they tend to lead to bony fusion. And acute anterior inflammation of the eye, and anterior uveitis, is the commonest extra-articular manifestation. And luckily, this episode, usually patients get maybe 4, 5, 7 times these recurrent attacks, but it's very easy to treat. It responds very nicely to topical steroid eye drops and also dilatation of the pupil, and tends to heal quite easily. So this is the most common extra-articular manifestation. Others are psoriasis, inflammatory bowel disease, and then these features listed on this side are uncommon, including some patients may get aortic valve involvement and conduction problem. Rarely, some of them may need pacemaker, but these are very uncommon. Sometimes the treatment-induced problems can happen, like hypertension and renal involvement is very uncommon. All these frequencies listed there indicate these are very uncommon. And spinal ankylosis with the osteoporosis, spinal fracture is a serious occurrence, and it is a big problem. I broke my neck also once. I was in Wales, which is part of United Kingdom, next to England, and over there, I can blame the Welsh for making such a strong sink. My chin couldn't break the sink. So, but we hope to prevent ankylosis so that this thing won't happen. And that's the current evidence that we may be able to slow down X-ray progression. So let's start with management now. Make sure that Professor Google or Dr. Google doesn't sell you snake oil and other things, and that's happening all the time. Unfortunately, people go to website because the doctors don't explain to the patient what is ankylosing spondylitis. And so stay away from those sites. There is one website called kickass.org. Kickass, yeah. But it's one S. Who is laughing? One S. Kickass.org. A non-kosher website. Stay away from that. Really, they will sell you, buy my book, How I Cured Myself, and how don't eat bread, and a lot of things that are totally nonsense. So there is one website that you all know, spondylitis.org, which gives you proper, useful information. And there is a federation of all societies dealing with AS patients worldwide, and that society is called Ankylosing Spondylitis International Federation. And So I spoke there on the similar topic, but it was upcoming better management of the disease. And Spondylitis Association of America is now actively affiliated with ASIF, Ankylosing Spondylitis International Federation. So patient education is absolutely mandatory. The word doctor does not mean a healer, it means educator. And if we don't explain to the patient what the disease is all about, don't expect compliance. And physical therapy, rehab training is very, very important in this disease. You will need to learn what kind of things you should do, shouldn't do, how to maintain your posture, chest expansion, and swimming is very good exercise, provided the pool is clean. And, and it has to be lifelong exercise. And also you may have to change your lifestyle. Sometime employment and every patient who gets diagnosed, luckily, who are lucky to get diagnosed at young age, because the mean age of onset is 23 in this country, 23. That's the prime of one's life. And those college students and young graduates should be told what profession is best for them. And don't become a dentist if you are all the time bent and doing cleaning the teeth. So complete avoidance of smoking, I will emphasize that a little later. I could tell you that for rheumatoid arthritis, smoking is a risk factor for rheumatoid arthritis. If you have a family history of rheumatoid arthritis, you are eager to get the disease, just smoke Marlboro and Camel all the time, you will get the disease. In ankylosing spondylitis, the evidence is there that it does worsen the disease. Very strong evidence. Also, there is one report that it may also be a risk factor for AS, but that needs to be confirmed. So, this is the most important component when you try to manage. And after patient education, you start with NSAIDs, non-steroidal anti-inflammatory drugs. They are very effective for this disease. And since the illness usually begins at young age, people don't have high blood pressure, they don't have kidney disease, they hopefully are not smokers, they don't have a stomach ulcer. So the NSAIDs are not that dangerous for those young people. When we become more senior, then you would have to consider benefit risk, but NSAIDs are extremely effective. They do slow down X-ray progression, especially when they are given in addition to the TNF inhibitors, which is the next form of management if patients don't adequately respond to NSAIDs. And both celecoxib type and the conventional naproxen type, ibuprofen type, they are all efficacious, but not everybody responds to one NSAID. So you'd have to try at least 2 or 3 NSAIDs within a month before you find the most suitable NSAID for the patient. And once the NSAID is given, it takes only 7 to 10 days for the patient to call you and let you know whether he or she is benefiting. For example, you can have a pain scale of 0 to 10 before treatment. Patient says, my pain level is 9. So after 10 days, he or she calls you saying, well, I'm feeling much better. And the doctor would say, how much better? Well, my pain score is now 4. That means the patient has really responded. So that you should stick with that NSAID. Those who fail to respond to one, try another. Within a month, you should have tried at least 2 or 3 NSAIDs before you start thinking of the next treatment, which is TNF inhibitors. And more recently, another type of medicine has become available that targets interleukin-17. I will discuss that in a minute. So the etoricoxib versus naproxen. Etoricoxib is a drug NSAID that is not approved in USA, but it is available in most of the other countries. And the only head-to-head study was done between these 2 NSAIDs. etoricoxib versus naproxen. And etoricoxib was better than naproxen. It's not approved by the FDA because etoricoxib cousin led to some problems and the drug was withdrawn. So the FDA hasn't been that eager to approve similar type of NSAID in USA. So this is the more complete recommendations proposed by ASAS and ULAR. And so it demonstrates that if NSAIDs don't work, you may try sometime sulfasalazine if there is a major peripheral joint involvement. Methotrexate does not work in this disease. It may help those few patients who have peripheral arthritis, but it doesn't help spinal disease. And so most of the patients who fail to respond to NSAIDs have to be given TNF inhibitors. There are many different TNF inhibitors. All of them are roughly equally effective, but the efficacy rate is not 100%. Many patients don't respond. Maybe 60% of the patients show response. And out of those, over time, there is a drop-off of efficacy, more so in women than in men. So there was a big need for something else. That something else finally came along because inhibitor of interleukin-17, another important cytokine that plays a role in inflammation, was found to be very effective, both for those patients who never received TNF inhibitors and those who had responded to but then lost efficacy or had side effects. And the surgery is needed when the joints become quite severely damaged. So hip joint involvement, hip arthroplasty has really been very helpful. Narcotics should not be given in any form of arthritis. So no Percodan, codeine, and so on, because that's not the pain is due to inflammation. By numbing the brain, as it is getting signals from inflamed side, is not the way to go. And so there is no need for narcotics. There are rare exceptions when somebody is, there's nothing else could be used. Those are rare exceptions. The next slide shows the data that indicate that sulfasalazine has some effect. You can see the p-value of the two curves, placebo versus sulfasalazine. Sulfasalazine decreased the what is called BASDAI listed there on the left side. That BASDAI over here means Bath Ankylosing Spondylitis Disease Activity Index. So this is placebo and this is the decrease indicating improvement in symptoms. While leflunomide, another drug like methotrexate, they are used in rheumatoid arthritis, they were not effective, and methotrexate also. So pamidronate has been given for some patients who failed to respond before TNF inhibitor came along. It is given intravenously, but it's not really that effective. So I would not encourage, I've not used for patients pamidronate. In China, they use thalidomide. You remember thalidomide story where children were born without arms and legs? But in China, studies, open label studies, the one control study showed it is effective, but slowly, the effect is seen slowly. So don't use thalidomide in USA, but they had reason to try because Chinese population, they didn't have TNF inhibitors up until recently. And so they would use it for short time, then discontinue, try NSAIDs and traditional therapies. So I'm just mentioning thalidomide just for China. The next slide is the typical outcome of AS patients given TNF inhibitors, in this case etanercept, and patients' different ways of monitoring their disease activity shows that there is improvement. And this ankylosing spondylitis disease activity score is the one that is currently recommended for assessing response to treatment and following. So, for example, this patient, that score was high, and over passage of time, the disease has been under good control. And not everybody has this kind of a persistent response, but many patients have been on treatment for years and with good control of their disease. So the new treatment, secukinumab, was approved for psoriatic arthritis and psoriasis and ankylosing spondylitis a couple of years ago, 3 years ago, and it is fully human monoclonal antibody that targets this particular cytokine called interleukin-17. There are different types of interleukin-17, A to F. So it is very effective, and it also doesn't have black box warning because it has less of the serious side effects. And there is no head-to-head comparison between secukinumab and other TNF inhibitors, except one study where it was shown to have, but I can't discuss which is better than other because of the situation. I can't discuss treatments, okay? So I'm just telling you that, I'm discussing management, but I don't want to advocate which one is better than other. So mostly the TNF inhibitors are the ones that are used if NSAIDs don't work, and if they fail to respond, then interleukin-17 inhibitor. Then there's another cytokine called interleukin-23, and for that, this ustekinumab is very effective for psoriasis, psoriatic arthritis, but not effective in ankylosing spondylitis. So here is the example. Here is what happens in ankylosing spondylitis. Patients over the years get stooping of their spine, the neck stoops forward, the chest expansion becomes less, the breathing is more diaphragmatic rather than chest expansion gets limited, and hip joint may get involved. So the trick is to recognize the disease when the patient are in this shape and maintain them in this shape. That can only be achieved with regular exercises, control of symptoms, and especially some biologics that can prevent bone fusion. And so the data dealing with secukinumab are very encouraging. 4-year data have shown that 80% of patients on treatment with secukinumab maintain the integrity of the spine. They don't start fusing up, which is very good news. For ankylosing spondylitis, it took more than 4 years. It took more than 4 years before one could show slowing down of axial progression. So hopefully time will come when patients will stay in this situation. And you may have heard about Dan Reynolds. If not, you should know about this guy. I could have put his picture here, but I didn't feel like doing it without his permission. But has the illness for 6 years, and his diagnosis was delayed for 6 years. And he's apparently, whatever he's doing, I never asked him, but he has maintained himself very, very well. And it's interesting that he has 2 brothers also with ankylosing spondylitis. one of them is a physician. And yet, the youngest brother, his diagnosis was delayed for 6 years. One can recognize the illness within months if the patient comes to us. Earlier this year, I recognized the disease in an individual who had symptoms for only 2.5 months. By definition, you have to have symptoms for at least 3 months before you can call it the disease. But it so happened he lives opposite my home. He just knocked the door. And his symptom was a lot of fatigue. And so I let him speak. I didn't look at my wristwatch to give him a signal to stop talking. And the diagnosis was obvious. Then I asked him, have you read a textbook about this disease? He said, no, I have not read anything. And so if you let the patient speak, the presentation is so typical, you can strongly suspect the condition. And sure enough, we recognize his illness. He's on treatment now and doing pretty well. What about tablets? Oh, by the way, with secukinumab, the local injection site reaction is almost unheard of. Out of 600 patients, one had stinging and discomfort. So that's also useful to have these things. When you self-inject, they ideally shouldn't cause local reaction. But what about tablets? Well, there is some hope. Tofacitinib, which is approved for rheumatoid arthritis, also was approved for psoriasis, psoriatic arthritis. There are phase 3 studies. That means the studies that FDA needs to see before they decide whether it should be approved for ankylosing spondylitis. At this meeting, we will know about the result of these studies. And apremilast works for psoriasis, psoriatic arthritis. You probably see the advertisements on TV all the time. But for AS, it wasn't effective. Now, what about other drugs that are very effective for rheumatoid arthritis? The two diseases are very different. What works for rheumatoid arthritis doesn't mean it would work for ankylosing spondylitis. So rituximab is very effective for rheumatoid arthritis, but in AS the data were not that good. Abatacept doesn't work in spondylitis, and also inhibitors of interleukin 6 are also not effective, and anakinra, which targets interleukin 1, that is also not effective. So for ankylosing spondylitis, the important cytokines, the protein molecules that create or cause inflammation, are only two: TNF inhibitors and interleukin 17. Other cytokines play a role in other diseases, but not in ankylosing spondylitis. And now I have to emphasize about smoking. Here is the data that should tell you if you are a smoker, better quit. But smoking is, nicotine is so addictive, it probably hits the same receptor that cocaine hits. I know people who quit cocaine, but they couldn't quit smoking. And so here is the information. If you are a non-smoker, okay, if you are a non-smoker and your CRP is normal, that means you don't have active inflammation, your risk of getting bony bridging measured by this thing called MSAS, okay, over 2 years, the chances are 13% if you are a smoker, but only 4% if you are a non-smoker, okay? Both have normal CRP. Those who have elevated CRP or ESR indicating active disease, then the difference becomes even more. 20% if you are a smoker, 7% if you are a non-smoker. So this is when there is no bony bridging. Patients in early stage of the disease, when there is no bony bridging, you can see why wise patients should quit smoking. Now, what if there is already beginning of bone effusion in the spine? Then if the CRP is normal, there is 33% chance of progression over 2 years of spinal progression, spinal fusion progression, 33%, versus 19% if you are a non-smoker. What if you have elevated CRP and you already have syndesmophytes? If you are a smoker, 55% chance over 2 years you will progress. That means a very severe rapid progression. Only 2 years you are showing more and more bony bridging. And if you are a non-smoker, 40%. So smoking is an environmental risk factor for worse outcome. And disease activity in male smoker has at least 10-fold amplified effect on X-ray damage in comparison with female non-smokers in AS. I think now I'm getting a signal that I should be stopping. So I will just show you the last thing. The radiographic progression is strongly dependent on those who have B27. They get more severe disease. Males get more severe disease. Smokers get more severe disease. If you already have inflammation on MRI, when X-rays are normal, that's an indication of more severe disease. If you already have bony bridging at baseline, you will get more severe. Hip involvement, also patients get more severe disease, and those who have elevated CRP and ESR. So these are the items that indicate greater chance of X-ray progression. And quickly then, there is a strong link between the gut and spondyloarthritis or ankylosing spondylitis, because even asymptomatic patients with AS, 50 to 60% of patients, if you do the biopsy, there is evidence of subclinical gut inflammation. So there is a strong link between the gut and ankylosing spondylitis. And this is the second last slide to indicate that there is the possibility that for ankylosing spondylitis, if you have TNF inhibitor and interleukin 17, both targeted by the same molecule where one end attaches to TNF, the other end of the antibody attaches to interleukin 17, maybe the effect would be more amplified. But the studies are undergoing at the moment, too early to say whether they would work or not. And the other thing I must tell you that prebiotics, probiotics, antibiotics are not the way to go in this disease. There is no scientific evidence yet that you will benefit from those things. And so these are the concluding remarks, and I will be glad to answer questions. Thank you for listening.